again, everyone, and welcome, of course, to the continuation of this week's IVF Series weekly live stream, featuring, of course, Dr. Oybek Rustamov, a member of the Royal College of Obstetricians and Gynecologists of the United Kingdom, and has completed subspecialty training in reproductive medicine and surgery at Cambridge University Hospital's NHS Foundation Trust. Dr. Oybek holds a postgraduate research degree from the University of Manchester and has extensive scientific expertise in the evaluation of ovarian reserve and ovarian stimulation in IVF cycles. Now, for today, Dr. Oybek will cover additional three steps from yesterday's presentations. He'll be tackling about cause of fertility, female fertility workup, and ovarian reserve. So with all of these, Dr. Oybek will go through each steps, and then right after each steps, we will have Q&A with Dr. Oybek. And those who are watching right now, feel free to simply message us with your questions or send them via rustamov.com.au, or you can also simply type in your questions by sending a direct message to our official Facebook page. That's www.facebook.com/Rustamov. So, without further ado, ladies and gentlemen, let's welcome right now, of course, fertility specialist and clinical doctor, Dr. Oybek Rustamov. Good morning.
Hi, JC. Thanks for a kind introduction. Good morning, everyone. So thanks for joining the live stream. So we'll continue yesterday's stage, which is stage 1. So as JC said, we will be covering step 5, step 6, and step 7. That will conclude all female workup we need to do before starting IVF treatment. So we start with step 5, which is female causes of infertility. So we will, here we are in still step 5, reproductive health. So female cause of infertility. So we'll break this session down into two parts. First, we will examine normal reproduction and how normal reproduction works. Then, on the basis of this knowledge, we will discuss what could cause infertility. So, reproduction, like its name suggests, involves production of sperm and egg, gametes, and the creation of embryo and child together. So, like any production process, this whole reproduction process needs regulation and production of the gametes and delivery of the gametes. So in the body of female and male, and there are certain specific organs, specific structures responsible for each of these steps of reproduction. So regulation is governed by pituitary gland, which is located just on the base of the brain for both men and women. So a production of the gametes, like sperm in men, is undertaken by testes, and production of eggs is responsibility of ovaries in women, and delivery of the gametes is responsibility of vas deferens in women, and men, and fallopian tubes in women. So we can see there's a specific organ for regulation, production, and delivery in human reproduction for male and female. So like in any production process, you need messengers or the messengers who relay the signal and the command. So the hormones play the role of the messenger here. So from pituitary, FSH and LH hormones are produced. Exact same hormone was men and women. In men, the role of pituitary is the stimulation of the specific cells in the testes to make them produce testosterone, and stimulation of specific cells called Sertoli cells to make them produce sperm. And so exact same hormone stimulates ovaries in women to produce estradiol hormone and egg. So so essentially, so pituitary produce same hormones to regulate whole human reproduction, same for male and female. So any problem in any of the stages of this production process can cause infertility. So today in this talk, and today we will not cover male fertility, and this week we will start male series and we'll be discussing the cause of male fertility in much more detail. Today we will focus on causes of female infertility. So, okay, so we start again from the top. In terms of regulation level, what could cause infertility? So this is mainly linked to the pituitary diseases, mainly having low FSH and LH, which is usually linked to genetic condition, which is very rare. It's not very common. And also linked to high prolactin levels. That's usually caused by something called benign growth in the pituitary. We call it pituitary adenoma. So, and also severe chronic stress can cause pituitary dysfunction, which can lead to infertility. Mild short-term stress doesn't usually disrupt fertility very much, but severe chronic physical and mental stress can cause fertility problems. It's kind of body's defense mechanism where if women or men undergoing severe stressful events in their life, body protects them and doesn't let them to conceive. So, and also being severely underweight or overweight can act like severe stress for the body, and it can cause pituitary dysfunction and can lead to infertility. So, and the next, in the level of production of the eggs, we see two problems: quantitative problems and qualitative problems. Usually, the quantitative problems can cause lack of release of eggs or ovulation. So this is linked to the two different spectrum of the amount of eggs women may have. So one is having too many eggs, called PCOS. In PCOS, women may have a very high number of small follicles, and usually none of them manage to become dominant follicle. So, and that can cause anovulation, irregular periods, and despite having lots of eggs, they cannot release the eggs. And also having low ovarian reserve or diminished ovarian reserve can cause anovulation, which means they are simply running out of stock of eggs, and it can cause irregular ovulation, which will result to irregular periods. So in terms of quality of eggs, in this category, women can release the egg, but because of the qualitative issue in the eggs, they may not achieve fertilization, implantation, or pregnancy, or having a child. So that's usually linked to the age, like we discussed yesterday, and could be caused by medical or genetic conditions. So now we will cover the third level of this reproduction process, which is the delivery. Delivery of the gamete, here it's egg, into the sperm where the fertilization takes place. So that happens in this ampular part of fallopian tube. So so problem is the delivery can happen due to mainly two reasons. One is having blocked tubes, or having tubal adhesions. Blocked tubes, of course, as the name suggests, the tube can be completely blocked or partially blocked, and on one tube or both tubes, where sperm cannot travel to this part or egg cannot travel to this part of the tube. And also the tubal problem can be caused by tubal adhesions, where the tube is stuck because of adhesions, scar tissue, cannot freely move and capture the egg for fertilization. So, and both of these problems, tubal blockage and tubal adhesions, usually caused by infection. Usually it's chlamydia, and may be caused by other infections or endometriosis. So, okay, so now we have, let us say, covered regulation, production, and delivery of the gametes. So then we have two more steps before we can achieve successful pregnancy. So first is a fertilization of egg with sperm. That again, as we said, happens here in the tube. So the tube is responsible, and also in addition to the fertilization, tube is responsible for incubation of embryos for 5 days. Tube work has a function of passage of the egg and sperm and embryo, also the function of incubation. So both of these functions of the tube should be intact to have a successful pregnancy. This is why in some patients, tubes may be patent, but they may not achieve pregnancy. Still, it may be linked to the function of the tube. So, and the next step is implantation of embryo in incubation of the embryo for 9 months during the pregnancy. Implantation happens after 5 days after fertilization. It takes 5 days for the embryo to travel back into the uterus. Then endometrium should create optimal environment for implantation. So here we have got 5 levels. So disruption any of these levels can cause problems in this fertility. So in terms of like this textbook cause of infertility, we know can be put into any of these boxes in male or female fertility reproduction process. So in some patients, we cannot actually find the cause, and we don't know what is actually the cause which is causing infertility, and we simply call this category of the diagnosis as any unexplained infertility. So so overall we can see that the problems of in reproduction can arise in any of these steps of reproduction process, and the understanding of individual patients, individual couples, the problem helps us to formulate right treatment strategies for them. So this end of my first presentation, JC.
Thank you so much, Doc, for that one. Now, okay, at this point, ladies and gentlemen, that was the cause of infertility. Now we will move on with some Q&A, and feel free to throw in your questions in our social media pages where the live stream is, of course, being broadcasted. Or you can simply message us at www.rustamov.com.au. Now, Dr. Oybek, here is my question to you with regards to that step 5. Can you still have infertility if one of the fallopian tubes blocked and the second tube open?
Yes and no. So essentially, there's a degree of the impact of the each cause or factor to infertility. So just simply fact that the blocked tube, even if it's one tube, indicates there was some processes, some pathology in the past, usually linked to infection or endometriosis, which resulted to blockage of that tube. So that indicates that other tube might have been also affected, because if it is chlamydia, for example, it equally affects tubal mucosa in both tubes. So simply, which means that other tube may be patent, open, but may not be as functional. So, and of course, when women have a healthy or open tube, yes, they can conceive. Simply the chance can be reduced. So, and also, yes, it really depends on individual patients in terms of degree of the damage to the open tube.
All right. Thank you so much, Doc, for that, for clarifying that to everybody. Now, I suppose it's time for us to move on with the next step, which is step 6, which is, of course, the female fertility workup. So, Dr. Oybek, please.
Yes, thanks, JC. So essentially, this will be pretty much the beginning repetition of what we just presented, because a female fertility workup is directly linked to the causes of infertility we want to establish. So we'll do a quick run through again of the process of reproduction. So this is step 6. Okay, so here in this presentation, we will discuss two things. So in terms of workup for fertility, which means establishing the cause of infertility for the couple, and second, a general workup, which means to assess overall health and well-being of the couples, and so that they will be prepared for fertility treatment and pregnancy. So so we will again mainly focus on female infertility next week. This week we will be covering male infertility. Again, we'll just run through quickly the fertility. For healthy reproduction, we need optimal regulation of reproductive function, then production of eggs and delivery of eggs to the tubes, by the tubes, and the delivery of embryo to the uterus in implantation. These are 4 the different levels. So in our investigation for fertility workup is focused on establishing if there is any disruption in any of these levels. So let us start from the regulation. So taking very detailed, comprehensive history is extremely important. So, and usually history will shed light to the most of the problems we see in infertility, and it will direct us what investigations we should perform to either establish presence of certain disease or exclude that disease. So again, in each step we start with history. So when we are taking history, investigating for possible cause of pituitary problems, we ask about the establishment of first menstrual cycle. If there is genetic cause of pituitary problems, and the women may have a very late period, late menarche. So, and then regularity of the menstrual cycle. If there's genetic cause for the pituitary problems, women may have amenorrhea, which means they may not have any period. So then we establish if they are undergoing any stressful life events in terms of mental stress, physical stress, and also we will look for the symptoms of high prolactin levels. High prolactin levels may cause breast discharge. So, and we directly ask question if we suspect the patient may have a pituitary problem. Then also, as we discussed earlier, having very high BMI or body weight, or being underweight, severely underweight, may cause pituitary dysfunction. This is why we have to establish patient's body mass index. So, and then in terms of pathology, the tests, we certainly need to check FSH, LH, and estradiol. This test is typically done at the beginning of the cycle. It's day 2, day 3 of the cycle when these hormone levels are in the lowest point. So, and patients with a pituitary problem, primary pituitary problem, have a very low FSH and LH levels, so, and estradiol levels. So then to find out if there's any sign of pituitary problem in terms of like adenoma, we check the prolactin levels, and we check thyroid function test, which is directly linked to the pituitary function. So these are the minimum blood tests we need to run to investigate for pituitary problem, which may cause infertility. If we suspect that there is any pituitary adenoma or benign growth, then we have to request MRI scan and of course discuss with endocrinologist. So so the next level is we will actually check if patient has a good ovarian reserve, and also if patient is ovulating. So in terms of good ovarian reserve, again, we take the history, we look for the symptoms of diminished ovarian reserve, premature ovarian insufficiency, where you have irregular periods or absence of periods. And also we look for the symptoms of PCOS, which can be linked to the, again, not having any period, we call amenorrhea, or irregular periods, which means having period every 2-3 months. So, and also we look for symptoms of PCOS like excessive hair growth, acne, and having increased body mass index, which is often associated with PCOS. In terms of tests, we should do anti-Mullerian hormone tests, because AMH tests, like we discussed later and on step 7, is directly linked to the ovarian reserve and number of growing follicles. Patients with PCOS have lots of follicles, like in this picture, and they produce lots of AMH hormone. So, and on opposite end of that spectrum, patients with low ovarian reserve or diminished ovarian reserve have a very low antral follicle count on ultrasound scan, smaller number of follicles, and very low AMH levels. So, and also we check testosterone, 6-hormone binding globulin to establish if there's if patient has PCOS. In terms of assessment of ovulation, the best test we use is a progesterone. So progesterone is a very objective marker for ovulation. So if patient is ovulating, usually it's approximately 7 days before their period, they have a high progesterone level. So, and this is the routine baseline test for ovulation. So, and certainly patients should have an ultrasound scan. So on ultrasound scan, we do full pelvic scanning. In addition to that, again, count number of small follicles. This is called antral follicle count. Antral follicle count means the number of small follicles which are visible on ultrasound scan and measure less than 1 centimeters. So, and patients with PCOS have a very high antral follicle count, more than 25 total hydrofollicle count. And also, we look for the typical sign of polycystic ovaries on ultrasound scan. So this will be minimum investigation we perform to check if patient is producing eggs and to check the ovarian reserve. So next level is we check if actually the produced eggs are being delivered to this part of umbilical part of the tubes for fertilization. Which means we have to take a history to find out if there is any risk factors in the history which may cause tubal diseases, tubal problems. We ask if patients had any PID, chlamydia, history of severe endometriosis, history of previous ectopic pregnancy, which may be linked to the tubal problem, and history of pelvic surgeries, which may cause pelvic adhesions. Yeah, and then in terms of investigation, we check if patient has chlamydia or gonorrhea. Then perform pelvic ultrasound scan and look for the typical signs of tubal problems like hydrosalpinx. In hydrosalpinx, you have a sausage-like structure instead of tubes. And also look for the sign of frozen pelvis, which means severe adhesions in the pelvis, which could indicate patient may have a tubal problem. And in terms of direct tests to check the patency of the tubes, we do HICOSY, which is ultrasound scan and injection of fluid, where we see if fluid is passing through the tubes, or hysterosalpingogram, again, injection of fluid and taking images under X-ray to check if the tubes are open. So if you're not quite sure if this test results inconclusive, you still want to find out whether the tubes are open or not, then laparoscopy and dye test is one of the most definitive investigations for that. Here, patient needs to have a keyhole surgery. Dye can be injected directly, blue dye, and we can see if the dye is passing through the tubes directly under vision. So these are the tests for tubal patency. All these tests actually show if structurally these tubes are patent or not, but functionally, as we discussed previously, the tubes may not be patent, especially if they had a previous history of pelvic infections. Because if infection damaged the mucosa inside of the tube, it may reduce their function. So the next level is implantation. Once fertilization takes place here in the umbilical part of the tube, then embryo should travel. It takes 5 days for the embryo to reach inside the uterus and should implant. When embryo arrives here on day 5, it should land in very optimal endometrium, because from the end of day 5, embryo starts hatching and growing, attaching to the endometrium and growing its placenta. So for that, endometrium and whole uterus and whole physiology of the women should be optimal. And there are certain conditions which can reduce the implantation. We need to look for the signs and symptoms of these conditions when we take history, take obstetric history. If patient has got severe endometriosis, which may impact the implantation, history of pelvic infection, history of any fibroids, polyps, uterine abnormalities. And if patient has got any large fibroids, pelvic abnormalities can be detected with pelvic examination or on pelvic ultrasound scan. If patient has multiple fibroids, if patient has submucous fibroids, we may need to do MRI scan to establish exact location, size, and number of fibroids. So in terms of surgical investigation for fibroids, severe endometriosis, laparoscopy and hysteroscopy is most optimal surgical intervention. So these are the workups we do. So these are the basic workups we do. And if patient gives additional history like recurrent miscarriages and other conditions which needs to be investigated in full, then we request additional investigations. So this concludes our fertility workup before we start IVF treatment. Then in addition to that, we do general workup. So the objective of this general workup is to establish the couple, especially female patient, is healthy and in optimal health to start fertility treatment and pregnancy. So again, we take full medical history, surgical history, check body mass index and blood pressure, and run a number of tests to check their overall well-being, and then also check their immunity to rubella and varicella to ensure that there's no risk for the developing fetus. If they get rubella and varicella, if they're not immune, then we recommend doing immunization. Then also we check blood-borne viruses for blood-borne viruses before starting fertility treatment. Yeah, so this is you'll see end of my step 6 presentation. Thank
That's
you.
right. Thank you so much, Doc, for that. That was the female fertility workup, our step 6 in this series of IVF. Right now, of course, it's open now for again for some Q&A. And once again, we would like to remind each and everyone to please do feel free to throw in your questions if you have any in our social media pages where the live stream is, of course, being broadcasted. And you can also message us at www.rustamov.com.au. Now, Dr. Oybek, here is my question with regards to female fertility workup. How do you check if a patient is ovulating?
Yeah, so good question. So again, we start for if when we're investigating for any disease or any condition, we first start with history. So history tells us a lot in terms of even for ovulation. So we ask patient, we establish when they start having period, when they were in teenage years. Then also we ask menstrual history and regularity of the menstrual cycle. If patient is having a regular cycle every month, every 28 days, that pretty much indicates most likely patient is ovulating. There's not objective evidence of ovulation, but it indicates most likely ovulating, because in order to have a period, you need the progesterone hormone. So you should have ovulation, then produce progesterone hormone. So if someone is having regular period, means that most likely they're ovulating. In terms of detecting of ovulation, so you can the simplest and reliable and objective method is a progesterone test. So progesterone test increases 7 days before the menstrual period if patient ovulated in preceding cycle, which means if patient has 28-day cycle, we check the progesterone levels on day 21, and we should see high progesterone levels. Typically, it should be more than 30. So if patient has an irregular period, if they have a 35-day cycle, then we should do progesterone levels on day 28. Because it may be too early if you do it on day 21. That's the simplest, because it's just simple blood test. So then other means of checking ovulation is checking LH levels by monitoring and blood tests. That is again very accurate, but that requires number of blood tests to pinpoint exactly of the search of LH hormone and estradiol and progesterone hormone. So, and which we use actually for IVF cycles, in frozen IVF cycles, to monitor and pinpoint exact day of ovulation. But it may not be very practical for the patients because they have to do blood tests and they need to be monitored by fertility clinic. So, but it is a reliable method. And home LH kits using urine, and they're not as accurate. So as blood tests, and also other way means of checking is ultrasound tracking. An ultrasound scan, you can keep tracking the number size of follicles, and you can, if you keep doing scans, you can actually see the ovulation information of what we call corpus luteum after ovulation. Again, it's very cumbersome, and it's the patient may need a number of ultrasound scans. So yeah, so there are different ways of establishing ovulation.
Thank you so much for enlightening, of course, our viewers with regards to that question, Doc. Thank you. Now, at this point, of course, we're down to, of course, our last step, which is, of course, the ovarian reserve. So, Dr. Oybek, please go ahead.
Thank you. Yeah, this is our last presentation for today. Yeah, so we will cover ovarian reserve here. So that's very, very important topic, because eggs, as we said, quantity of the eggs and quality of eggs must fundamentally units of female fertility, and also our investigations in terms of understanding couples infertility and formulating treatment is really focused on understanding the ovarian reserve. So we will discuss ovarian reserve in very detail in this presentation. So this is step 7, last presentation on female workup series. So first we will actually understand ovarian reserve. Second, we discuss markers of ovarian reserve, and third, and how we use this information to formulate right treatment for the couples. Okay, so women born with a set number of eggs in the ovaries, and as they get older, they lose ovarian reserve. Let us say this is age 0. They were born up to the age of 46 here. So interestingly, some women born with a low number of egg reserve, and they lose their ovarian reserve much faster, and they become infertile much faster than other women. So some women born with a normal ovarian reserve, and they have a normal duration of their fertility, and some women born with very high number of eggs in their ovaries, and they stay fertile much longer, and they have late menopause. So it appears that number of eggs women born with determines their long-term fertility when it comes to ovarian reserve. This is one piece of knowledge which helps us to understand individual patients' ovarian reserve and fertility in their treatment. So, and we use now we are moving to the next part of this presentation, which is the markers of ovarian reserve. Marker means that the tests we can use to establish ovarian reserve of each individual women. Yeah, so we use 4 different markers: age, FSH, AMH, and AFC. So among these 4, 2 of them are very accurate, AMH and AFC. We'll explain why. So age is very good marker, but it's relative, like we've seen here. Let us say the patient of same age may have 3 different ovarian results. So that's why it is relative. So okay, so let us cover one by one. So age, like we said, fairly reasonably accurate, but again it is relative. So FSH, like we discussed earlier, produced from pituitary gland. Actually, FSH hormone is produced in response to ovarian activity. So it's not direct ovarian hormone. It's not directly produced from the eggs, growing follicles. So if a patient has a low egg number, they have a higher FSH because pituitary will be trying to push ovaries harder to work harder to produce eggs. So this indirect marker. And also FSH is prone to variation during the cycle. So you really have to measure FSH at the beginning of your cycle, day 2, day 3 of the cycle. If patient has irregular menstrual cycle, and if you end up measuring FSH wrong time, it may give false positive or false negative results. So, but still be used as a marker of ovarian reserve. Now we're moving to the reliable direct markers of ovarian reserve, AMH and AFC. So anti-Mullern hormone is produced from antral follicles. You know the antral follicles we discussed earlier. When you do ultrasound scan, you see tiny follicles, which is less than 1 centimeter. These are called antral follicles. And these tiny follicles produce anti-Mullern hormone from their follicular cells, called granulocyte cells. So if patient has a lots of small tiny antral follicles, they have a high AMH levels. If they have a little number of antral follicles, they have a low AMH levels. So these antral follicles appears to be reflection of invisible tiny primordial follicles. You can see these follicles called primordial sleeping follicles. They're not visible on ultrasound scan. They're not active. They're sleeping. But if you have a high number of primordial follicles, it appears you have a high number of growing follicles. So if we see high AMH, we can conclude this patient has got a lot of small antral follicles currently, which are producing high AMH levels, and that's reflecting of how much small sleeping primordial follicles they have in the ovaries. Then we can predict saying, okay, in future they have lots of stock of small follicles, and their fertility is longer than expected. So this AMH, and this is a direct marker. So the second, the first test is antral follicle count itself. So, which means actually we can count small antral follicles, which is producing AMH, on ultrasound scan. We call it AFC. So, a sonographer can just look at cross section of the ovary like this. You can see the cross section of ovary, and they can count all the follicles they have: one, two, three, four. Then only take the ones which is less than 1 centimeter and say, okay, these are antral follicles. So you count on the left ovary and you can count on the right ovary and then add these two. Then you got total antral follicle. Let us say if you have 7 antral follicles on the right, 8 antral follicles on the left, then you have total antral follicle of 15. So this antral follicle and AMH actually correlate. Usually, if you have AMH of 15 in average, you have antral follicle of 15. No wonder, because they're mirror image of same thing. We're measuring exactly same thing. One, we're measuring structure on the scan, and then we're measuring the hormone that structure is producing in the blood test. So this is mirror image, and they are direct marker because they're being produced from the side wall of the growing eggs. So, and let us now move to the third part of this presentation. This is how we can use this knowledge to understand individual patients' ovarian resolve and formulate their treatment. So here, AMH and AFC, let us say, we're measuring the patient's AMH and AFC. Let us say, if you just go by age, if you don't use these markers, this is fictional 20 friends of the same age. Let us say classmates, all 34. You could assume that they have a same or similar fertility because their age is the same. But if you measure the AMH or antral follicle count, then you can actually find out they have 3 different level of ovarian reserve and 3 different level of fertility. So let us say these 5 friends, Jessica, Ashley, Amanda, Sarah, Jennifer, may have a very high ovarian reserve. And these 5 friends may have very low ovarian reserve, and the remaining 10 may have average ovarian reserve. So essentially, by just simply doing AMH test or antral follicle count, we can actually tell each person's individual ovarian reserve. And that can help us to give them right advice in terms of planning their future fertility or right treatment if they're having fertility treatment like IVF. And now let us see how we use this information in IVF treatment. Of course, we're discussing pre-IVF workup. So we check every patient's AMH and antral follicle count and use that information to formulate their dose of stimulation. So let us say for these 5 patients who have a low ovarian reserve, we use high dose of stimulation, which means we need to give them higher dose of drug to push the ovaries a little harder to get optimal number of eggs. And then these 10 patients, we should give average dose of ovarian stimulation to get again optimal number of eggs. And for 5 patients with a very high ovarian reserve, we should be careful and we should give them a lower dose of gonadotropin drug. If we end up giving them high dose of gonadotropin, they may develop ovarian hyperstimulation syndrome. So so we use this information to understand each patient's ovarian reserve. Second, to give them advice for longer term fertility. Third, we use the same piece of information to formulate the IVF treatment cycle. That's why it's an extremely important test. That's overall the discussion on ovarian reserve and markers and how we use ovarian reserve markers in IVF cycle. Hi, Jesse.
Thank you so much, Doc, for that one. Thank you. All right. Now, at this point, of course, Doc, we're down to our last question, specifically for this step. So I'd like to ask you this one. Can you treat low ovarian reserve and, of course, increase women's ovarian reserve?
Um, Short answer is no, because
Okay.
ovarian reserve, like we can see here, determined at the time of birth, yeah, the number of follicles, number of eggs women have. If you investigate further, then it is essentially determined by mainly genetically. Yeah, maybe 70-80% of amount of eggs women have at birth is determined by the genes they inherited from their parents. So, and yes, there is a impact of epigenetics, environmental, developmental factors, of course, medical factors during their lifetime up to the point of trying to conceive. There are a number of factors, but the biggest impact is made at the time of the creation of eggs, even before they were born. So there are different theories of creation of new eggs during lifetime. And yes, there are some fundamental biological studies, some of them suggesting it could be the case, which means women may create, but there isn't any strong convincing evidence on that. So basically, there's a strong evidence that all eggs women have created at the time of birth, and we cannot create new eggs, which means we cannot treat low ovarian reserve, and we can only give right advice and optimize usage of all, the remaining ovarian reserve optimally, and help them to achieve pregnancy if it is at all possible. So yeah.
All right, thank you so much, Doc, for that one. Now, there you have it, ladies and gentlemen. And of course, those were the extensive presentations on cause of infertility, female fertility workup, and also the ovarian reserve. Now, please go right ahead, each and everybody, to check out all our social media pages and our website, rostomov.com.au, for more information. And next week, we do look forward to another exciting discussion, of course, with Dr. Oybek Rustamov, fertility specialist and clinical doctor, as he empowers women to be the architect of their own fertility health. So again, Doc, I'll see you again next week, I suppose. And if you can take, at least tell them a glimpse of what they will look forward to for next week's IVF series.
Yes, yes. Thanks, Jesse. Yeah, so this week we will be covering male infertility, a male workup, let us say. We will be doing a number of presentation, daily presentation for the remaining of this week. And next week, in one or two live streams like this week, we will be going through everything in much more detail. So our focus will be in male fertility workup. And please attend our live streams if you get a chance. Thanks, JC, and thanks everyone for watching. I wish you a great day ahead, and we'll catch you next time. Thank you.
Thank you, Doc. Thank you, everybody.